So just so everyone knows, welcome to the CCIM4 webinar. Today we're going to hear from Laura Brinson. Just a couple of quick announcements. Welcome. I think everyone has already heard me say to enter their name, county, in the chat bar. And if you would like a copy of these presentation slides, please include your email address. The presentation is going to last about 15 minutes. So please stay muted during this time while Laura's talking so she can work her way through. And I will interject every about 5 minutes just to keep us on schedule to make sure that we have enough time at the end for Q&A during the last 15 minutes. And then the recording of the webinar will also be posted on the website that you can see there. So just so everyone's aware, the CCIM4C is the Community Collective Impact Model for Change Initiative, funded under the Federal 21st Century Cures Act as part of Ohio's state targeted response to the opioid crisis. We are working with 12 Ohio communities to address opioid use and misuse at the local level, combining strategic planning and an emphasis on working across the continuum of care using a trauma-informed approach. Ohio Mouse is also partnered with Ohio University, the Pacific Institute for Research Evaluation, and Prevention Institute to develop these training and technical assistance resources. So we hope to prevent opioid use and abuse, reduce opioid-related deaths, and increase access to treatment, including medication-assisted treatment, on the state of Ohio. And if you'd like more information, you can find that on our website on this slide. So this webinar series hopes to bring together those in the field with experiences, who have had successes, and also challenges that they can offer their wisdom to us and our communities that are facing similar issues, and then provide additional resources, strategies, and content to our CCIM4C communities and those that are partnering with them at the local, state, and national level. Today's webinar, as I mentioned, is Laura Brinson, presenting on regional naloxone distribution, coordination, and evaluation. So I will hand it over to Dr. Brinson.
Thank you. So my name is Laura Brinson. I am a substance abuse health educator with the Northern Kentucky Health Department. And part of that role is being in charge of our naloxone distribution and evaluation program. And then how do I change the slide?
Do you see the arrows at the bottom of your screen?
At the bottom? Oh, yes, right there. Okay. Thank you.
Great.
All right. So to get started, just a couple of things that I would like you to walk away with. But, of course, at the end, if you have any questions, please let me know. I'm going to talk about our three important components that we have to our multi-site community naloxone distribution program, and then also some solutions for barriers that we've experienced in collecting data. So just a little bit more information about the Northern Kentucky Health Department. We serve over 400,000 residents in our area. That is 4 counties to the south of Cincinnati: Boone, Kenton, Campbell, and Grant. And like most health departments, we take care of the essential health services. So our divisions include population health, that's where I am out of, our clinical services. They also do our syringe exchange programs, and that we have in 3 counties: environmental health, and then, of course, our administration. So that's a little map of our area. It's pretty diverse. We go from an urban area up to the north bordering Cincinnati and the Ohio River down to Grant County, which is pretty rural, and then everything in between. One thing to note, we have been, and I'll go over some data in a few seconds, but we have been hit extremely hard by the opioid epidemic, especially in comparison with the rest of the state of Kentucky. And a lot of that is due to 75 and 71, which run through our area, which, of course, makes it very easy to get around. People are very transient in this area. They may work in one county, but live in another, and then shop in a third. But, of course, that also helps to facilitate the spread of drugs as well. So a little bit about substance abuse in our area, Northern Kentucky. So 3 of those counties, Boone, Campbell, and Kenton, they have pretty much consistently listed among the top 5 counties in Kentucky for heroin, fentanyl, and fentanyl in combination overdose deaths. And then additionally, back in 2016, when the CDC issued their list of 220 counties at an HIV outbreak like the one experienced in Scott County, Indiana, both Campbell and Grant counties were on that list. I know this can be kind of hard to see, but this is a heat map showing our rates of acute and non-acute hepatitis C. We've got graphs going from 2010 to 2015, 2010 to 2016, and 2010 to 2017. And this is really just to show, as a heat map, how the areas are getting darker as the rates of hepatitis C are going up. And then down at the bottom, there is a bar graph just showing year after year that count. I think the official count for 2017, I'm not sure if the numbers are still coming in, but we had over 1,300. One thing that we are also experiencing is that in December 2017, both the Northern Kentucky area and then Cincinnati, Hamilton County started to realize a shift in HIV cases. It wasn't necessarily that our HIV cases were increasing, but rather the HIV cases, the risk factors were changing. So in 2016, we saw 25 total HIV cases in our area, which is not a lot, with only 5 of those HIV cases being attributed to injection drug use as a risk factor. In December of 2017, when we began a cluster investigation to really look at this change in risk factors, from December 2017, or rather beginning of 2017 to October 3rd of this year, we've seen 80 cases of HIV, new cases, and 44 of those having injection drug use as a risk factor. So, of course, injection drug use, opioids, overdoses, hepatitis C, HIV, these are health issues that we're experiencing that are very much tied together. So some of our strategies with regards to that, we do have syringe exchange programs. We have ones running in 3 of our 4 counties. We also, through those syringe exchange programs, in addition to naloxone distribution and clean injection equipment, we offer connections and referrals to other services, and then also assessments for treatment and referral. We do HIV testing and outreach that has really ramped up as we have seen this increase in cases among people who inject drugs. We also offer HIV case management for the 8 counties in our area, so those of another health department as well, to be able to provide medical case management and other linkages to care and resources. We have a long history at our health department of supporting community-based substance use prevention efforts. Part of my role is providing technical assistance to each of the 4 county drug coalitions in our area, and then, of course, naloxone distribution.
We're at the 5-minute mark, just to let you know.
Very similar to the law that is in Ohio, the Good Samaritan law. We have the same one in Northern Kentucky, and it basically just says that anyone, if they're acting in good faith, can administer naloxone, help somebody in the event of an overdose without experiencing civil or criminal liability. So what is naloxone? Narcan is the brand name for naloxone. That's usually the title or name that you see. And it's a medication that's known as an opioid antagonist, and that counters the effects of an opioid overdose. It does that by blocking the opioid receptors in the brain, counteracting its effects on the central nervous and respiratory system. Most often, with an opioid overdose, the respiratory system, breathing is affected, and Narcan is what allows the person to begin their breathing again. So just kind of an illustration of that, you can see when somebody has an opioid overdose, their opioid receptors in their brain, they become flooded with the opioid, and what the Narcan does is actually move those opioids off those opioid receptors and replaces them. Different forms of naloxone. What we use for our community program, we distribute the nasal naloxone kit. They tend to be the easiest for folks to use, and they feel most comfortable using that as opposed to the injection naloxone. And our kits come with 2 4-milligram doses. Narcan naloxone will work on any opioid, whether it's a street opioid, such as heroin or fentanyl, or a prescription opioid. We are mostly seeing in this area more and more fentanyl as opposed to heroin. We also see a lot of polysubstance use, but a Narcan will not work on things like cocaine, benzodiazepines, and alcohol. Oftentimes we see folks using drugs in combination, so that's one thing in our community education say, especially when it comes to the community, Narcan is extremely safe, FDA approved, and even if somebody has not had an opioid overdose, it will not harm them. But it's one of the easiest things that you can do to save a life. Just a little more on the, very few negative side effects. Usually the person will go into immediate withdrawal, which we inform the person of. And while that's unpleasant, it's not necessarily life-threatening. So just a little bit about the history of naloxone distribution in Northern Kentucky. We were awarded a grant from the R.C. Dura Foundation. It's a local foundation in our area. Back at the end of December 2016. Because before then there were a lot of individual community groups that were distributing naloxone, but there was no real one entity to be able to coordinate those efforts. But folks, community action groups in our area, there's a logo there for PAR, People Advocating Recovery, had really been giving out naloxone for years in our area, very grassroots, out of the trunk of their cars just to make sure that they could get naloxone in the hands of those that needed it. So at that time, December 2016, we were awarded a $250,000 grant, and that grant pays for staff time, training stipends for individuals to conduct trainings, needle stick resistant gloves, especially for law enforcement, sharps containers, rescue breathing masks, and the naloxone itself. So we had some questions when we were setting up this program since we were taking charge, and the foundation was really stressed to us the importance of collecting data, felt that we were the entity in the area that could collect data and really do an evaluation to see if these efforts were working. So we decided to ask ourselves, who's a priority for these free kits? Who can distribute naloxone? What should we include in trainings? How do we collect data? How do we store it? And then how do we best serve the entire region with limited resources? I know that my concept of money has definitely changed, just with the price of naloxone. It's $250,000, which is a lot of money, but it also, it is limited at the same time as well. So we decided when it came to who would be a priority for our free naloxone kits, we looked at SAMHSA's opioid overdose toolkit. So people in treatment or who have recently completed treatment, those who use or are prescribed opioids, those recently released from jail or prison, family, friends, loved ones of those using opioids, those who have a immediate medical need due to overdosing, and then law enforcement. We decided who could distribute naloxone. A lot of that was based upon our agreement with Adapt Pharma, that's the manufacturer. They do have a preferred purchase price for government entities, but there's some stipulations with that. People distributing that naloxone have to be law enforcement agencies, fire departments, first responders, health departments, local school districts, colleges, universities, community-based organizations, and they have to provide it for free. So that right there kind of answered our question about who, in addition to us, can distribute the naloxone.
So there's 5 minutes left, Mark.
Agencies also have to have an appropriate medical protocol or standing order to be able to give out the naloxone, which is becoming pretty common now that doctors sign off on that. We work a lot with our detention centers, our community action groups, our quick response teams, which are law enforcement officers, social workers that go out after an overdose call to be able to get Narcan in the hands of people who need it, and then also, the people that are most likely to use it or be affected by it. When it came to the training, this is a list of the things that we include. We wanted to kind of give the lay of the land with the data, also let people know, what an overdose looks like, how they can prevent an overdose from even happening, whether it's talking to their doctor about their prescription drugs they're on, or not using alone if they're using substances. Responding to an overdose, how they can keep themselves safe, and also how to get a replacement naloxone kit if they do use it. When it comes to the data that should be collected, we looked at, because we were doing a lot of agency trainings and agency staff versus the general public, what data did we want to collect? Oftentimes when we're collecting for staff members, their employers don't want to know a lot of personal things, so we really pared that data down that we collected. Identifying what risk factors there are for overdose or witnessing an overdose, common responses to overdoses, and then getting the contact information for somebody receiving a kit. That's kind of twofold. We want to have contact information in case there's a recall, so we can let folks know, but then also so we can contact them 6 months after receiving a kit to be able to follow up and see if they've used it and what the circumstances were. And that, of course, was the most important part to our funder, knowing how much naloxone was getting out there and if it was. These are some screenshots. It'll be easier once the slides are sent out to really see what's on those forms, but this is what our baseline survey looked like. Just asking who the person is, had they witnessed an overdose before, what did they do, but then also looking at do they have any instances of past drug use, and what did that look like as well. This is our locator information form. We last got a lot of information just because some of the population that may be receiving the Narcan may be harder to get a hold of in 6 months, but really wanting to have as much as possible so we can connect with them. One of the big concerns, especially with our syringe exchange programs, was what if the person is hesitant or declined to give their information. We always let them know that their information is confidential. It will be used to improve the program. But we definitely stressed, especially to our clinical staff, that if somebody feels uncomfortable answering something, they don't have to complete all of the questions, and above all, still provide the naloxone. Having that naloxone for somebody that needs it and can save a life is obviously more important to us than having the data. We also had a question of how the data should be collected and stored. We have people going out and doing trainings out in the field. Our concerns, of course, were cost, but then also privacy as well. So what we did with our trainers that we worked with in the community, they had paper forms for outreach that could be filled out with locked bags for transport, and then we used RedCap, which I believe is probably available through your local university. I know we get ours from University of Cincinnati. For data entry and report generation, it is HIPAA compliant and it is free to use. So this is a little more information about RedCap. We got ours because it's free for members of the Center for Clinical and Translational Science and Training out of the University of Cincinnati and Children's Hospital. We also liked that it was HIPAA compliant. That was a necessity, but that it was cloud-based, that it can design surveys, databases, and we can always just export the data into whatever system that we want to be able to generate reports. I think our final question was, how do we best serve the entire region with limited resources? We gave priority to those groups that were listed by the SAMHSA opioid overdose toolkit, but while we do have the naloxone, even if it's just a concerned citizen, we will give them a kit as well, because we found, especially in our area, really anybody is at risk for witnessing an overdose because it's become so widespread. We also make follow-up contacts at 6 months and then 2 months before product expiration for a few reasons. We want to collect data on the naloxone use, see if it was successful. Encourage individuals to pick up a replacement kit, because if they've used it once, they will most likely use it again. And then what we also do is, if people are bringing the kits back to us 2 months before product expiration to get a new one, we divert that naloxone to our local law enforcement and first responders, because they have a chance of using it quicker, and it's a good way to be able to use those resources. This is just a little bit of information on our follow-up survey. We basically want to know, who did they use it on, what other things did they do to help the person that was having an overdose, and then, of course, what was the outcome. So these are some of our stats for our most recent fiscal year, so July 1, 2017 to June 30th of this year. We distributed 1,909 naloxone kits. 309 were through our county health centers. We have 1 in each county. And then 1,527 kits were distributed in the community. Some of those community groups included civic organizations, social service agencies, support groups for people in recovery, our local court system, and then schools. Over that time, we had 157 lives saved, reported back to the health department. That included 80 by local law enforcement that carry naloxone, and then 77 by our health centers and the residents in the area. In terms of how successful that is, the only thing that I could find was an article that they had done in San Francisco about, if you distribute this many kits, what should your rate be of lives saved? And they had about 10%. So, we're kind of right on track with what the literature says in terms of success of the program, and that's what we know about. We would expect that there are more people that have been saved. We just don't know about it. And at this point, I would like to ask if there are any questions.
So please feel free to unmute yourself now and ask questions of our wonderful presenter. Thank you so much. Or you can type in the chat box, so we'd love to hear your voice. I see Tyra's typing.
How long will the current grant funding pay for the program? So we are coming to an end of our grant funding now. Initially, that grant funding was really only supposed to last about a year, and we made pretty good use of our funds. We were also able to leverage donations of naloxone from Aetna, the Medicaid Managed Care program here in Kentucky, as well as United Healthcare, which is another Medicaid Managed Care plan. So we were able to supplement some of our grant funding with that. We would expect that probably in the next couple of months or so, we will be out of that original funding. We have, of course, submitted applications to our local ASAP board and other entities for additional naloxone kits. One thing in order to be able to spread resources that we've been piloting is through our Syringe exchange program. We had received some donated injectable naloxone, and it seems to have gone pretty well. That being a recommendation from somebody else that works in the area, saying that population, if they're injecting drugs, they don't necessarily feel shy about using the injectable naloxone. So we're piloting distributing it at those sites, and that will definitely reduce cost. We pay about $75 a kit for the nasal spray, while the injectable to get 2 doses and 2 syringes is about $37. So we're looking at that as a way to really kind of spread our funding, but then also keeping the nasal aside for a community member, somebody that would feel a little bit hesitant about using the injectable. And then the slides, I am not sure how we are taking care of the slides, but I know that they will come out.
Yeah, I think Holly's answering that question in the chat bar.
Okay, thank you. And the other question, did you find it difficult to enlist your other distribution sites? Is the survey paperwork a barrier in gaining new sites? I would say that wasn't necessarily a barrier because of the price of naloxone and the fact that we were providing it for free. That was a pretty big incentive. When it came to enlisting our other distribution sites, of course, they were going to do it in the clinics because they are best equipped to do that. And then when it came to our community partners, they had received some other grant funding previous to us, in which they had to fill out paperwork, so they were used to that. I will say probably the biggest barrier was just for me reminding sites to turn in their paperwork, but in terms of their willingness to do so, it really wasn't an issue or a barrier to them, distributing the naloxone. Usually it's on the individual side, somebody not wanting to fill that out. But again, we would, if they refused, we would still give them the naloxone kit and then ask the person that was doing the distributing to just record the expiration date, the date that they trained the person, and the location, just so we had that data, so we at least knew the kits were going out.
We still have someone typing, so I'll give them 1 minute. Any other questions?
Do law enforcement document administration of naloxone? If so, what form do you receive from them? So that's an interesting partnership. We work with our local healthcare system, which is St. Elizabeth Healthcare, and they also provide naloxone for law enforcement. So what we will do is that I will go out and do the initial training if the law enforcement agency has not been trained in the administration of naloxone, and I'll get baseline data from them and give them kits. And then because they are 24/7 typically in their line of work, and they may be using a naloxone kit at 3 o'clock in the morning, and they need another one, what our local healthcare system has them do, they have sites, emergency room sites in each of our 4 counties. They can go in and fill out a little card, which is ask for a little information, like who did they use naloxone on, what made them think that they were having an overdose, what other things did you do besides giving naloxone, like, you know, for instance, through a sternum rub or something like that. And then also if they were transported by EMS, they fill out that little postcard, they will give that to the pharmacist on duty, and they can get their refill kit right there in the emergency room. So what happens with that, and they've got those cards that they bring into the emergency room, which the pharmacist on staff, and then those get faxed to me, and then I take care of the data. So that piece is definitely in conjunction with our local hospital system. We do have quite a few, I want to say probably about 50% of our law enforcement agencies in the area carrying naloxone. So we've made some pretty good inroads by just keeping reminding them that we have free naloxone and how easy it is to use to be able to get law enforcement agreeable to that. But so they have a little bit different of a process, but they fill out a card before they can get their refill.
That was a great question. Anything else before we close down the webinar today? Just a reminder, the presentation will be sent out via email if you type your email in the chat box. And the recording of this webinar will be posted on the CCIM4C website, which you can find at this link. Thank you so much for presenting today. It was very useful information. I'm sure the people on this webinar and those who will watch it in the future will find it very helpful. And the next scheduled webinar in our series will be on Friday, December 14th on the DEHERA project, and then we also have one scheduled for Monday, December 17th on harm reduction statements. So thank you again so much.
Oh, you are most welcome. And then my email address is on those slides, so if you have any questions, please don't hesitate to reach out to me. If you would like copies of the forms that we used, if you're interested in starting up your own program or just need some more information, please let me know and I can send those as well.
Thank you. That's very generous of you. So this concludes our webinar today, and thank you all for joining.